Good morning, everybody, and welcome to this edition of Spartan Talks. My name is Sam Chen. I have the privilege of serving on the faculty here at Northampton Community College and serving as your host for Spartan Talks. So grateful to welcome those of you who've been with us before back, and for those of you here for the first time, welcome to Spartan Talks. This is a TED Talk-like platform featuring our fantastic faculty here at the college, who, as many of you know, are also experts in their field outside of the four walls of the classroom. And we have an exciting talk today, and I'm really excited about introducing our guest. Our guest is Dr. Kate Muller. She teaches in the psychology department here at the college and has been at Northampton since 2018. When she's not here at Northampton, she's the founder and director of the Valley Center for Cognitive Behavioral Therapy, a psychotherapy practice in Bethlehem, Pennsylvania. And she also serves as supervisor and instructor for Rutgers University's Graduate School of Applied and Professional Psychology. Her specialty is in clinical treatment of anxiety disorders, and her research interests include community-based efficacy studies of exposure therapy. She is an alum of Rutgers University herself and completed her postdoctoral training at the University of Pennsylvania's Center for Treatment and Study of Anxiety. She's a sought-after guest. She's been on locally here, Channel 69 News, but also on National Public Radio, in the Wall Street Journal, CBS Evening News, and of course, everyone's favorite, WebMD. When she's not doing psychology, she says that her interests are in the sci-fi fantasy world and has apparently presented at several cons over the year. And I'm thinking we're going to need to do another Spartan talk on that because that is just right up my alley.
Oh, that's great.
Her current hobby is genealogy, and just a fun tidbit she shared with me in a recent genealogical research, she's discovered that her 11th great-grandfather was actually one of the founding settlers of Salisbury, Massachusetts in the 1600s, and then later accused of witchcraft. So those of you who remember your American history or have read any literature from that era, this is a piece of history right here we have at the college. Of course, Dr. Muller's talk today is on exposure therapy, and specifically the idea of facing our fears and using exposure therapy for anxiety. Now, you didn't come to hear me talk, so I will shut up, and without any further ado, please join me in welcoming Dr. Kate Muller.
Thank you. I love that introduction. Thank you so much, Sam. It's a pleasure to be with you all today, and hearing about the witchcraft piece in my family's history was fascinating to me, and it fit right in with that sci-fi fantasy stuff that I'm into already. So I'll be continuing to explore that. That's my side interest right now. I spend most of my time treating anxiety disorders, and I'm very passionate about that too. So I am thrilled to have the chance today to talk to you a little bit more about a specific type of treatment that I provide called exposure therapy. So I'm going to go ahead and share my slides with you. Hopefully I can get them up here. Let's see. And get started with letting you know a little bit more about exposure therapy. So I'm just going to ask Sam if there's a problem with the slides, you give me a heads up, but I think we're good here. All right, awesome. I want to talk with you a little bit about what exposure therapy is and what exposure therapy isn't. So facing your fears is a big part of what we do in exposure therapy. And I am fascinated over the years as I teach. I usually ask my students, and I teach usually first-year students at Northampton, and then fourth, fifth, or sixth-year students, which would be grad students at Rutgers. I ask them if they've heard about exposure therapy before. And I have to say, I'm thrilled because each year that I teach, more and more people know what this therapy is. It used to be more of an obscure, weird sort of therapy. And the fact that it's become more mainstream is really exciting. Facing your fears, exposure therapy. What is it? Why do we do it? And this notion of exposure is sometimes the mystery to folks. So I would like to introduce this through an example. And I'm going to go ahead and show you guys a quote first that I like to show my clients. And I show them this quote a couple times during therapy, the beginning, the middle, and especially at the end. And this is Eleanor Roosevelt, one of my heroes, talking about fear. And she says, you gain strength, courage, and confidence by every experience in which you really stop to look fear in the face. The bold here is mine. You must do the thing you think you cannot do. And that gives you a sense already, hopefully, about what exposure therapy might be like. Doing the thing that you cannot do. In the case of anxiety disorders, doing the thing that scares you the most. And we'll get into that a little more. To get started, I want to talk to you about a little friend of mine who happens to be my kid, actually. This is my son, Nathan. And I'm sorry, I'm just tweaking my camera here a little bit. There we go. This is my son, Nathan. And I want to talk to you a little bit about Nate and the vacuum. So as you all can probably figure out, we're talking about a vacuum here, but Nate was 20 months old and his nemesis was the vacuum. And I got his permission. He's now 8. So I got his permission to use some of these pictures and to tell his story. He agreed. And he, in fact, encouraged me to use the word nemesis because he is very much into dragon books and dragon slayer books and these kinds of things right now. He also plays Minecraft. And so this idea of nemesis was right up his alley. So Nate was 20 months old. He has a twin sister too, Izzy. And out of the blue at 20 months, he becomes afraid of our friend, the shark vac here. This is more recent version of the shark vac. He was scared of one about 6 years ago, but he became terrified of it, terrified of the noise, terrified of the sight of it, terrified of the closet that we kept it in. Anything related to this vacuum, even to the point where we would go to Target or Walmart or somewhere like that. And if we turned the corner where the vacuum display was, he would start crying, get upset, and tell us to go somewhere else. Not exactly sure how the fear developed. As a psychologist, of course, it's the peril and the perk of being a psychologist kid. I thought it must be something to do with the noise. Maybe it's kind of tall. It was taller than him. Maybe there was something to do with that. So we embarked on Nate's exposure therapy. And I put exposure therapy in quotes because it wasn't exactly therapy, but it really is an example of what I do with my clients and what exposure therapy looks like for people in the real world, for adults who are coming in and asking for this sort of help. So how did we treat Nate's phobia of the vacuum? Well, we did it slowly, and we did it with multiple approaches to vacuums. So let me show you a little bit here. Again, when I look back, I think, oh, I probably took these pictures just because they were very cute. But the psychologist in me was always thinking, well, this is interesting. We're doing what I do every day in my office, but in a sort of less structured at-home way. So we start with a play vacuum, a pretend vacuum. It's a little dirt devil. It actually does make noise, but the noise it makes is not as loud as the real vacuum that he was afraid of. So we got one for him, we got one for his sister, and they started playing with them. You can turn the sound off. So we started playing with them without the sound. We gradually added the sound to it. In the second picture, there is the actual offender, the vacuum right there, but we did not charge it. So there was no way to turn it on. You could step on those buttons, he could play with it, he could move it around. We were trying to create almost a friendship between Nate and the vacuum. And you can see his other little toy there in the picture. So that was a push toy he was using. We tried to almost make the vacuum like another push toy that he could play with at home. So eventually we get to our last picture. This is sort of the end of his exposure therapy. He's now gotten used to the vacuum at home. He's gotten used to the sight of it, where it lives in our house, the sound of it. And he and my husband in the picture there were going into the vacuum section at pretty much every store we could go to, touching the different vacuums, looking at them. And eventually, he not only got used to the vacuum in our house, the noise, the sight of it, but he also became an aficionado of vacuums. He wanted to go to the vacuum section every time we went to a store. So the moment you walked into Target, vacuums, 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 we had to go see them. We had to touch them. We looked at all the colors. And in fact, we then upgraded to a Dyson, and he was the one who picked it out. So at about age 5 or so, he was very proud of himself that he picked out the Dyson vacuum that the family would use. Again, it's a little bit lighthearted here talking about Nate's exposure therapy, but the concepts are exactly the same. The notions that we used here to help Nate overcome this are the same that we use with our clients every day when we offer them exposure therapy. The idea that instead of avoiding something, so some parents might have said, well, I'm just not going to vacuum when the kid is up. I'll wait till he's asleep, or we'll put it away every time he gets upset or yells. Every time he cries, I don't want to upset him. There's nothing inherently dangerous about a vacuum. There's no reason to avoid it or hide it or put it away. Much better to help the person get accommodated or used to the thing that scares them. So the notion here is very much the same that we use in the type of therapy that I offer. So moving on from this, I'd like to talk with you a little bit about some basic definitions and then move on to telling you about some other patients, other clients of mine who we've done exposure therapy with. So quickly, fear and anxiety. I pulled these definitions right from one of our primary sources as psychologists, the American Psychological Association. We want to make a distinction, a slight distinction, between fear and anxiety. Fear is a basic, intense emotion that's aroused by the detection of imminent threat. When I teach, and some of my former students are here, you might remember me saying things like, fear is, oh my God, there's a tiger. And the tiger is right there in front of you, and you're detecting that threat to your life. Anxiety is an emotion characterized by apprehension, that the thought that something bad may come, often with some somatic symptoms, heart racing, sweaty palms, feeling hot, feeling nervous, impending danger. And so again, to my students, I would say, maybe there's a tiger around that corner. Maybe there's something bad coming. So fear is this evolutionary gift that we have that keeps us safe. Anxiety, however, is the anticipation or the apprehension of a bad thing happening. And a lot of times there really isn't a bad thing coming, but our bodies and brains are acting as if there is. Anxiety persists, and all anxiety disorders fit this mold. Anxiety persists because of avoidance. Avoidance of places, people, things, images, thoughts, and emotions connected to the thing that started the fear in the first place. So to treat anxiety, we better be addressing and treating avoidance as well. So what is exposure therapy? What is this thing that I'm suggesting? Well, we'll give you some background there. It's a psychological treatment. It is a form of cognitive behavioral therapy, also called CBT. I am a cognitive behavioral therapist. And for those who've taken Intro to Psych, or maybe now that you're here at this talk, you might want to take Intro to Psych. CBT is a form or a theoretical approach to psychotherapy. It differs a lot from more traditional approaches like Freudian psychoanalysis or humanistic or existential therapies. It looks at the way we think, feel, and act. And we, as therapists, try to address those three things to make people live the lives that they want to live. Exposure therapy specifically helps people confront their fears by exposing, here's that word, exposing them to the things that they fear and avoid. Helping them not avoid, hide from, ignore, dampen down responses to, but face, and as a therapist, a really important concept to me, feel the anxiety. I hinted at avoidance before. Avoidance may work in the short term. If you have a panic attack in response to something, or you're anxious about something specific, like let's say flying or heights, it may help you in the short term to avoid that thing that scares you. And you can probably get away with avoiding flying, let's say for quite a while. I mean, there are some celebrities who don't fly at all, right? They refuse to go to Europe, or they'll take a train, or they have a special tour bus. So if you got the bucks, you could probably avoid it for the long term. But what if you want to go somewhere? What if you want to travel? What if you want to see the sights in New York City and go to the top of one of the tall buildings, Rockefeller, the Empire State Building? You will be limited then by your avoidance. So short-term avoidance may work, but long-term avoidance ends up making anxiety worse. we actually have some research that suggests that when you avoid, your brain is primed to create more intrusive thoughts and images. And we see this a lot in obsessive compulsive disorder. So if someone has a scary thought or image, I might hurt my kid, let's say, and they try to push that thought away, they don't allow that thought in, they're terrified of it, it actually seems to kindle more scary thoughts just like that. A little bit more about exposure therapy. We know that this is an effective and efficacious, and I'll explain that in a second, treatment for the following problems and disorders. By effective, we know that in community studies and everyday work, this helps, this works, but also efficacious. There are efficacy studies that have looked at this treatment in more controlled research settings. So where I did my postdoc work at UPenn, we were actually studying this, giving one client this treatment and another client does not get this treatment. And the outcomes were significant for exposure therapy. Phobias, panic disorder, social anxiety disorder, obsessive compulsive disorder, generalized anxiety disorder. And then I felt this was really important to put here, subclinical anxiety. So you may not meet criteria for one of these disorders, but you may have a fear or a worry or concern that actually keeps you from doing things that you want to do. It doesn't have to meet criteria for a disorder. You might be avoiding things and not doing things you really want to do because of it. So this treatment can help even with that. What exposure therapy is not. I sometimes think it's fun and useful to explain to folks what it isn't. So I love this cartoon. I mean, I was a big Far Side fan for most of my life. And this one is just, Gary Larson captures it perfectly. This is often, if anybody has heard of exposure therapy, this is what people are afraid it's going to be. Professor Gallagher and his controversial technique of simultaneously confronting a fear of heights, snakes, and the dark. Let's stick a guy in a box, hang him out a window, and throw some snakes in. The idea that we're going to take all your fears and shove you in a room and treat them all at once. We do not do that, fortunately. We would not have many clients stick around if we did it that way. However, there are versions of this that do exist. For example, snake phobia or dog phobia. There are cases where we do something called flooding, where we work with someone to quickly address the phobia by doing maybe over 24 hours, a bunch of different exposures. So you're sort of flooding them with the stuff that they're afraid of. There are 1 day or even 3-hour exposure sessions where we can do some of this. Would we do all 3 at once? No. And would we do it that way? No. The other thing that exposure therapy is not, systematic desensitization. It used to be called that. It used to come from that. That's the origins, basically, origin story of exposure therapy. But the issue here is that systematic desensitization is like exposure therapy paired with relaxation or paired with even medications like Xanax or Ativan that calm you down. What we know is that systematic desensitization, exposure plus relaxation, it works, but it doesn't work as quickly. It doesn't work as well. It also doesn't last as long, because in exposure therapy, what we're trying to do, and hang with me on this, this is where clients get a little panicky, is make you scared on purpose, make you even more scared than you may have been already. Because if you can tolerate that and stay with that, you can really do anything. You can see that this anxiety is not going to kill you, it's not going to hurt you. It can actually be something that you learn to live with and tolerate. And at that point, the anxiety tends to decrease. The other thing that exposure therapy is not, again, origin story here, counter conditioning. Counter conditioning was something done back in 1924 by Mary Cover Jones, an early female behaviorist, which we don't hear a lot about in the history of psychology. She designed counter conditioning as a way to kind of get rid of not useful learned behaviors and replace them with useful learned behaviors. There's a smidge of counter conditioning in exposure therapy, but it's different these days. It's not as behavioral and sort of reductistic as it used to be. I always want to put this slide in and tell people that, because still some of our textbooks refer to exposure therapy as either of these two things, and it really misses the bigger picture. Different types of exposure therapy. I'll cover this quickly because I really want to get to talking about some of my clients with you. In vivo exposure, which is real life, facing a real thing, object, place, person. Most effective type of exposure. If we can do the real life thing, we're going to try to do that. What if we can't though? What if the person is struggling with PTSD, post-traumatic stress, based on an injury, an assault, 9/11? You'll hear me talk about that with my client Nellie. We can't recreate that experience, but we can have the person imagine it. So we have them describe it imaginally and use that as our exposure. Virtual reality exposure is another option with the technology we have today. And by the way, NCC.
I think we may have lost Dr. Muller. There she is. She's back.
I'm sorry. I have no idea what happened there. That could have been our internet.
Welcome back.
Let me get those slides back up here. Okay. Hold on just a second. Can you see my slides there, Sam?
I cannot right now.
You can't. Okay, let me make sure I can get them back for us. Sorry about that, folks. I am not sure what happened. Okay, here we go. I think we're getting it back. That was one of my worst fears. So we're doing some exposure therapy right now. Okay, here we go. We're back to it. Can you guys see that video, the slides now? Okay, awesome. Let's get back to where I was here. Okay, virtual reality therapy was what I was talking about next. NCC actually has the technology for this, which is fascinating, and we love to show it in our classes. Flying phobia, fear of heights, even fear of public speaking. If we can't get a big group, we can actually do this type of exposure with you. Give you a way to do some exposure that creates a fake audience for this to practice to happen. And then also interoceptive exposure. And this is used mostly to create sensations that people fear. Run in place to get your heart rate pumping, create a spinning sensation. I have a client who had a fear of vomiting and feeling nauseous. And so we would spin her in a chair to sort of recreate that nauseous feeling. So there are a few ways that we can create the feared thing for each client. And I'm going to go ahead and talk a little bit about how exposure therapy actually functions as a treatment, what it does to help people. Habituation is the key here. Over time, people find that their reactions to their feared objects or situations decrease. The more you're around the thing, the more you do the thing, the less scary it is. And that's exactly what we saw even with my son, Nate. You get used to the thing, you make it a part of your life in some way, and it no longer scares you or freaks you out the way it did before. Extinction is the other piece of why exposure therapy works. It weakens a previous connection. We had a connection between, let's say, the vacuum and being scared and that scary sound and Nate being afraid that something would happen to him. Through exposure, he found that that terrible thing did not happen. Self-efficacy, a beautiful part of exposure. It helps you become confident that you can handle these types of situations in your life. And most of my clients report that it actually gives them confidence to face other things that might have made them anxious or worried. And then finally, emotional processing. A lot of us psychologists today believe in this notion of affective exposure, that people become almost phobic of emotions. They want to avoid them. They don't like to feel bad. They don't like to feel anxious. They don't like to feel scared. Exposure therapy helps you become more comfortable with feeling anxious, with feeling scared, and it just becomes part of your repertoire as a person. So let me tell you, sorry to just throw that tarantula up there, but let me tell you a little bit about some of the quick little snippets of therapy with my previous clients, and then we'll wrap up for today. Lisa, As these names have been changed to protect my clients, but I did get permission from each of them to talk about their stories. So Lisa came in with a spider phobia, arachnophobia. Early 20s, college student. She wanted to become a doctor. And as part of that, as an undergrad, she had the chance to go to Africa for a semester and not be a doctor per se, but assist and be part of a medical community there. And she was super excited to do it. And then she went to the information session. And they kind of gave everybody a heads up about what life in this austere setting would be like in living in sort of lean-to tent sort of situation, mosquito nets over the bed, lots of insects, and lots of other, in her words, local creatures. And that is when she pulled out of the program. She decided she would not apply, even though she really wanted to do it. And her father had heard about the treatment that we offered, and she came in to see me. So this long-standing fear of spiders, which she had prior to this, it presented as little things like, "Ooh, there's a spider on the wall. Dad, can you kill it?" She would never touch them. She wouldn't go near them. But it was never a huge deal because there was never anything it really got in the way of until this idea of going to Africa. There were large spiders in this area. She saw some pictures. Now, they were not tarantulas. They were not like our friend Rosie here in the picture, but they were larger than she was used to. And it did absolutely freak her out, the idea of sleeping at night and potentially one of these coming into the tent or being near her. So we did what we call gradual exposure, creating a list or a hierarchy of different spider exposures, everything from pictures and cartoons to movies like the movie Arachnophobia, to little tiny spiders that she was able to catch and bring into the session. And then finally, her graduation gift, Rosie, her exposure with Rosie. Rosie was a tarantula, Lasiodora klugi. I got super lucky because another client who had OCD loved tarantulas, and we were able to borrow Rosie for a final exposure session. And Lisa did beautifully, and she had some great graduation pictures where she's holding Rosie in the bowl. Rosie, when she is touched, sheds little spiky hairs, so we actually could not hold her, but we were able to hold her in the bowl. Okay, a little bit more. Post-traumatic stress disorder. I kind of hinted at this one. This was a client named Nellie. She was in her 30s, and she was present on 9/11 at the World Trade Center complex. Her building was not one that was hit, but she could see everything from the building that she was in. And unfortunately, rather than letting them evacuate, the building managers chose to tell everyone to stay. They could not leave. And so here they are, smoke, fire, and eventually she shared with me some really gruesome things that she had seen, as you can probably imagine, and that they could not leave the building. They were basically stuck in the building until they got the all clear to leave. So she struggled for years with panic, avoidance. She quit her job. She'd been working as a paralegal. She could not go back to the World Trade Center. She, in fact, was avoiding Manhattan altogether. She lived in the Bronx. And I treated her as part of a free program at Montefiore Medical Center in the Bronx, where we provided prolonged exposure therapy, which is a version of exposure therapy where we engage the client in retelling their experience of the trauma and add in some real life exposures. Like I had Nellie watching some videos of the day of 9/11, and eventually, and I had the pleasure of doing this with her, going back to the site. That was her sort of graduation item on her exposure hierarchy. She did wonderfully, and she keeps in touch with me. She actually talks about, like, anytime you want to talk about my case, my story, bring me in. I'm happy to talk about it. I thought this would be an interesting one to chat about quickly. My client named Chris, who had emetophobia. And if you know any of your roots, right? Emeto or anti-emetic, emetophobia is an extreme fear of vomiting. An extreme fear of vomiting or seeing other people vomit or feeling nauseous, almost like you could vomit. And Chris's persistence of this fear, it started when he was quite young, continued into adulthood. And for him, he thinks it was related to being very ill as like a preteen. He had gone out to dinner with his family and got very, very sick. And he remembers corn being one of the things he had eaten that night and then vomited up. And so corn became part of this picture for him too. And an example in this picture is one of the things that Chris did as part of his exposure. He had a hard time even saying the word vomit. He certainly could not say puke, barf, throw up, all these other slang terms that we have for vomiting. So part of his homework very early on was getting him to just write the word and then bring them into session and then tell me the word, read it off there. And then we finally got to things like vomit corn, throw up corn, barf corn. And he's sort of putting the two ideas together. We also had him spinning in a chair, watching movies like Stand By Me or Train Spotting. If you're a movie fan like I am, there's some great vomit scenes in those movies. And then eventually coming up with a vomit recipe. And you can find them online. The internet is beautiful for this stuff. It smells like vomit. And so creating that and then having him smell that was part of his exposure. Ultimately, do we make him throw up or not? It's always a question we have as therapists who treat this problem. In Chris's case, we did not really need to. He got so much better just doing these things. And even going to, like, he was afraid to go in any kids section of any store because kids are germy, right? They're vectors. So he would be afraid that if they had a stomach bug, he would catch it from them. So he got so much better doing the basic exposures that we really didn't need to make him throw up. But in some cases, there may be a client who we have to try to induce vomiting with so that they really feel what it's like and realize it's not as terrible as they think. And then finally, I'll leave you with a last client story, Rebecca, obsessive-compulsive disorder, late 30s. She was terrified of her child being harmed, not by her, but by someone else, and that it would happen surreptitiously. Someone would sneak in the house, poison her child, leave something dangerous around, and they would get hurt, and she would not have known, and she would be responsible. So she was doing very elaborate, significant compulsions and rituals, retracing her steps, setting up booby traps in the house where, like, she'd have a video DVD with a string connected to the doorknob. And then if it fell, she'd know that someone snuck in during the night. She had alarm systems left and right, excessive hand washing and sanitizing, to the point where her 2-year-old was, when he would play, you know, when kids play pretend, he would pretend he was pumping the hand sanitizer. That was like one of his play pretend things. Finally, she came to therapy and we got her out of the house. We got her to leave her child for a minute or two in another room. We went to germy places and risky places and even contaminated things on purpose. And she did wonderfully. And it really opened up her whole life and her son's life too. Now I have a little star there about pre-COVID. You can probably guess from what I'm saying that COVID has messed up some of these exposure opportunities for us. Fortunately, people with OCD and other things that involve contamination and fear of germs and things like that, their concerns are very specific. So unless someone's coming in with COVID-related specific OCD, we would treat things the way we usually do. And once COVID is over and we've got some control on it, we are going to go back to some of the usual exposures that we would do. I appreciate you listening to these cases, and I want to leave you with a quick slide about outcomes to tell you why this works. And these are some of the biggest selling points we have for presenting these treatments to clients. 60 to 90% of people after exposure therapy have either no symptoms or very, very mild symptoms. 60 to 90 is a meta-analysis, right? So if you pull these data apart, if you look just at, for example, OCD, we've got 80 to 90% recovery rates, extremely good outcomes that are lasting, they're durable. The effects of these treatments last a long time because you keep using the skills. You don't unlearn this, you can keep applying it. And then finally, the duration of treatment is actually quite short. It could be anywhere from 6 to 20 1-hour sessions. Some people need more, some people need even less, but it's a pretty effective and expeditious treatment. And then finally, the coolest stuff out there now is that we're looking at functional MRI scans of the brain and actually seeing morphological and structural and functional changes that are related to the therapy. These folks are not on medication. There's nothing else going on for them treatment-wise. The psychotherapy, the exposure therapy, is what seems to be working. I will leave you with another of my heroes, Carrie Fisher, who played Princess Leia. Princess Leia is one of my favorites, and she was a huge advocate for mental health, especially mental health for women. And she talked about her own experiences with bipolar disorder and addiction. She has this wonderful quote: "Stay afraid, but do it anyway. What's important is the action. You don't have to wait to become confident. Just do it, and eventually the confidence will follow." We modify it slightly with anxiety treatment to say, just do it. You will not feel fine. You will eventually feel better. So the action is what's key here. And then finally, there's my Leia getup. And I do, former students might remember this. They're kind of laughing. Yeah, this is what I sometimes wear for class. Done a little bit of cosplay in class just to keep it interesting. And that is my contact info for anybody who might have more questions. Thank you so much for listening. This was really fun to be able to talk with you about this today.
Well, thank you, Dr. Muller, for that fantastic talk, and for all the examples. I think that really helped bring things to life. At this point, we'll move to a period of question and answers. I got some questions here in the chat already. So
oh, great.
If you've got a question for Dr. Muller, please go ahead and drop it in the chat, and we'll run through these.
Okay.
So the first question, Dr. Muller, is, will this work for general anxiety caused by fear or emotions of feeling less than or inadequacies or situational anxiety? Does this work with clients who may have anxiety that comes out in sleep or dreams? And how does the exposure therapy look in that situation, if it's applicable?
It's a great question. I'll start with, so when we talk about general anxiety, we might be talking about two things. And the person who asked it, if you want to jump in, feel free. You've got what we call sort of general anxiety, that's sort of free floating anxiety. Maybe the person is like an anxious personality, right? So they sort of are anxious in lots of different situations. The treatment in that case takes a slightly different approach. It looks a little different. You would be talking about tolerating anxiety as an emotion state or as a sort of baseline. And you help the person maybe with some radical, we call it radical acceptance of that being how your body and brain work. And that can include exposures like when I'm anxious about a situation or I'm facing my day and it just feels overwhelming, learning how to do some of those imaginal exposures where you sit with the emotion and maybe even picture the bad thing that you might be worried about or the scary thing that might come later. We would come up with scenarios or even scripts. We often use video and audio in this case, where the person might record a situation that really makes them nervous, or I'm going to face my day and it's just going to be awful, or and then we'll get to the inadequate part, right? I'm inadequate, I'm an imposter, they're going to see through me, I can't do this, I can't make this work. And get those concepts into the exposure so that you feel some of that even outside of your everyday life. And the notion there is not so much to sort of cure you of feelings of inadequacy or worries that you're not good enough or worries about social evaluation. You might always have those, but to help those become more tolerable. We talk about like turning the volume down, basically, on that. So that's how that would look. The question of anxiety coming out in sleep or dreams, there are some more focused treatments. So for example, people who do have recurrent dreams, nightmares, that might be related to anxiety, there are some specific treatments for nightmares that we would use in conjunction with the exposure. So if we can get a sense of what the anxieties are, either from the dreams or from their everyday life, we might do some awake exposures in addition to something called nightmare rescripting, which is often used to help with some of the dreams or the nighttime anxiety. Great question.
Next question here. We got a lot of great questions here in chat, and they're still coming in, so keep them coming.
Oh, great. Okay.
Next question is, what threat was saying, so this is back to your example of the person who was afraid of vomit, I think it was, and you had them write the words out.
Okay.
What threat would saying the word you're afraid of be? How does someone get to that point of not even being able to write down the word?
Oh, so good. These questions are great. Yeah, so that is the power of avoidance, essentially. So in Chris's case, it started, we have this kind of early learning experience that was really awful. And Chris was fortunate enough, I guess, in a way, to not vomit from like age 11 to like 25 or something. 26, was he almost 30, actually, probably later, 29. And what happened there is that there was so much avoidance around the idea of throwing up or the notion of throwing up that even the words started to get imbued with meaning and anxiety. And so it started as avoidance of people and places. I'm not going to go to parties where people are drinking. He did not drink at all for fear of getting nauseous and throwing up, or getting tipsy or drunk and throwing up. He started to avoid things like commercials for beer. So if you're, or liquor, you're watching TV and something comes up, he would change the channel, because in his mind, alcohol equals nausea, equals vomiting. Oh, I can't even think about that. The feeling of vomiting. So videos, images, even sounds, like the sounds of someone retching or even coughing, would start to connect in his brain with vomiting. So the words began to connect, and he would avoid, mainly it started as he would avoid saying them. But then when he saw them, it became terrifying. And so he even avoided, I mean, how often are you saying puke, barf, unless you're a parent of a small child maybe, but you don't really, see or hear those words much. That he didn't have to use them, so they became really powerful. I didn't actually realize we needed to do that exposure until I started asking questions. As a therapist, you have to get really good at asking questions to figure out what the person's afraid of. Is he really afraid of throwing up itself, or is he afraid of the feeling of having to throw up? In his case, it really was about the feeling of having to throw up and not knowing if he would. So when I started going through my little checklist, I said, well, what about these words? Barf, puke, and I'm watching his face. And that was like, okay, so we need to do something with this. But yeah, again, great question. It's amazing. I think of anxiety as like tentacles. They sort of branch out and start taking over other bits if we don't address it. Mm-hmm.
This question, person says, I go through CDT, I think, and correct if I'm wrong, person who asked, I think you mean cognitive dissonance theory or therapy right now. And so it's different than this.
Huh.
How do you use this therapy when your anxiety comes from a chemical imbalance in your brain and not from a phobia?
Ooh,
for example, I often have no clue what makes me nervous.
It's a great question. And again, I'm guessing, I'm wondering if you mean CBT or maybe DBT. So cognitive behavioral therapy.
Yeah, I meant CBT.
CBT. Okay, great. Yeah. So cognitive behavioral therapy is think of it like an umbrella. It's a theoretical approach to life and to therapy. And under that umbrella, we have lots of different types of therapy. And so it's tricky for sure. The bottom line is, no matter what causes the anxiety, so if you are sort of thinking that maybe early trauma caused it, brain chemistry causes it, physical symptoms might cause the anxiety. The key is and this is probably the therapist's job, I'll be honest, to help the client figure out what you're afraid of. So even if it's caused by something else, there's something there that feels intolerable for you. And I'm not criticizing your therapist, by the way. I'm suggesting that there might be something, and it doesn't have to be a thing. It could be a feeling or a fear, and you can become afraid of a feeling or afraid of a thought even. And so a lot of times a client will come in and say, well, I'm anxious, but I'm not sure why. And as we start sort of digging around a little bit, it'll come up that I'm afraid of not feeling right. I'm afraid of one day waking up feeling weird or feeling unsure or feeling uncomfortable. Then the exposure is a little different. The exposure therapy becomes, let's get you uncomfortable on purpose. If we can do that and help you tolerate that, the world is yours. That, to me, that's the biggest piece of exposure therapy that I try to convey to people. If you can get used to this and habituate to it, let your body and brain get used to it, it no longer is something that you will fear. I hope that answered your question. I know it was kind of broad.
Thank you.
Of course. Thank you for coming.
Next question says, person says, thank you so much for this presentation. It's so amazing and interesting. My question is about how exposure therapy plays a role in trauma, especially childhood trauma. Does it help expose specific traumas and then address it?
Oh, great question. And I think you're already on track here. Your question shows that you're thinking about how this might work. Childhood trauma, of any type, could be anything from childhood physical abuse, neglect, loss, or even sexual abuse. And a lot of the work I did at UPenn with Dr. Edna Foa, her work was focused primarily on women who had suffered sexual abuse or sexual trauma, either CSA, childhood sexual abuse, or single event sexual abuse as an adult. When we think of childhood abuse, we often have multiple episodes or even chronic, right? Chronic abuse. The awesome thing about this therapy, and this is probably the nearest and dearest to my heart in this therapy, is the work that we've done with survivors of childhood abuse. This therapy can still be used. Now, we have to modify it somewhat. We will often start by getting a history of what the trauma entailed, in as much detail as the person is comfortable giving. And the way we work through that is then do imaginal exposure by having the person, and this sounds really hard, and it is really hard, describe in detail with their eyes closed, almost as if it were happening again, what they lived through. And for some people, one event became symbolic of that experience. So they could talk about one specific event that sort of stands out in their mind as symbolic of all that abuse. And for others, we'd have to pick multiple episodes of the abuse, and we would do exposure to each of those along the way. Very effective. Again, does not have to be a long-term therapy. In these studies that we were doing, we were probably having maybe more sessions, like 20 to 30 sessions of about 45 to 60 minutes each. And did we rid the person of their trauma? Of course not, but we helped it become part of their story, and we helped them no longer be afraid of the memory of the trauma. That's the key in exposure therapy for trauma. And if you'd like to read more about that, you can look up my former mentor, Edna Foa, F-O-A. Her work in prolonged exposure is stunning, and you'll find lots of great videos, and there's even a self-help book that she wrote, which is wonderful.
Dr. Muller, a follow up on that what you said at the end there about not necessarily getting rid of the trauma, but learning to overcome the fear or the worry of it or talking about it. Is it possible to get rid of, I mean, again, this is your field. From where I sit, I would find it almost difficult, if not impossible, to get rid of past events.
Yes.
Is that something that's possible to do, or is it that's impossible and therefore we have to deal with how we approach it?
You said it beautifully in that last sentence. It's impossible to erase our memories. And in fact, if we subscribe to my idea that avoidance is harmful, full avoidance would be let's pretend this never happened. Let's completely put it out of our mind. And we really don't think that's possible, despite some research in the 80s and 90s that looked at like forgotten memories or repressed memories. We understand now that that is highly unlikely to happen, that we want people to understand their own story. And so I sometimes talk to clients, especially with trauma histories, as you're coming in, you have a trauma. It is part of the book of your life, but it is a chapter that is so uncomfortable and scary and sad that every time you're reading the book of your life, you get to that chapter and you close it quickly and try to put it away. This therapy with assistance, right? That's the key in some of this, is that this might be really hard for someone to do on their own, but with the help of a trained provider, we're going to walk you through how to take that book off the shelf, open it up, and let's take that chapter page by page. Let's look at it. Let's open it back up. As scary as that might be, to let you own that chapter again and to have that memory. It will always be, like your question, Sam, it will always be there. It will always be sad. It will always be upsetting, and it might even be anxiety provoking, but the trying to avoid it, that is the thing that becomes troublesome. And so when we stop avoiding it and we understand it in the book of our life, we can go on into other things, and we can take that book off the shelf when we want, instead of having it intrude and kind of, here's the thing, your brain wants to process stuff. And we a lot of times walk around trying not to let that happen. And so exposure therapy is saying, okay, brain, let's chew this over. Let's figure this out. And you do it in a sort of structured way, safe way. Mm-hmm.
Comment here, and then our question. The comment is from one of our staff members here at the college, Amy Sams, over in our Center for Civic and Community Engagement. and she had one of our earlier questions as well, but she says here, Dr. Muller, you might be interested in the book by my friend and state representative Mike Schlossberg. Representative Schlossberg represents Allentown.
Yes.
He wrote a sci-fi fantasy, but is also a huge advocate of mental health and talks openly about his own struggles with depression and anxiety. The book is called Redemption, and it's the first book in the Spades trilogy.
Oh my gosh, I know who he is. I follow him on Facebook. I know his mental health record history, that he is a big advocate. I did not know he wrote a book. Thank you for that, Amy. I'm going to look that one up.
Sure. As soon as you said that in the beginning, Woo! I was like, oh, wow, that's a nice combination there.
Thank you. Oh, I'm excited. Let me check that out.
Okay.
That's, by the way, that is my dream, is to write the book. A book at some point, a sci-fi book. So we'll see if it ever happens.
Well, you already said you can do hard things, and don't let fear stop you.
That's right. Thank you. Right. Hard to practice what you preach sometimes. Thank you.
We have a Spartan Talk reserved for you when that book comes out.
Oh, I love it. Yes.
2 other questions here we'll get to. The first one is, how would you address the anxiety of perfectionism?
Oof.
Someone who has very high expectations of themselves. And, a lot of this question actually comes from one of my honor students. I think a lot of our honor students are in this boat. Perfectionism to the point that if those expectations are not met, one's anxiety is triggered and then leads to not wanting to do any activity at all.
Fantastic. What's the first name of the person who sent that question?
His name is Tess.
Tess. You are right on. And it tells me that you understand something about this already, because perfectionism and procrastination are part of the same spectrum. And oftentimes we see perfectionism. Now I'm a clinician, right? So I'm going to see it in its most extreme forms, where people are coming to me because they really can't get stuff done. They've gotten, they're out of school now, or they're not working because the perfectionism becomes so intrusive. But on a very basic level, the perfectionism that trips us up is also the thing that helps us succeed. So this is a complicated thing. We treat perfectionism with exposure therapy. And the perfectionists among us, because I count myself in there, I can't tell you how many times I went over these slides before I finished them. We force you to do things not perfectly. And so the treatment would involve things like, if it's your typical style to review something 10 times, we're going to start gradually by cutting you back to 2 or 3 times. And you're going to submit some things that are good enough and maybe not perfect. We also break down that procrastination. Oftentimes what happens for perfectionists is, if I can't do it perfectly, I'm not going to start it. I'm not going to do it at all. I know myself. I need my desk clean. I can't write until I have everything nice and neat and ready to go. We break that down and we talk about exposure to bits and chunks. And so if you have a paper coming up and you want it to be great, it's your final paper, it's for Sam's class, and you've got to have this great paper finished, and he's a great professor, and you really want to make sure it's perfect. You start by 5 minutes 2 weeks before, just 5 minutes, spill out whatever you can onto that page and stop and see if the next day you can do 10 minutes. And that type of practice that's based on time instead of I need 2 paragraphs or I need a page can really help you break through some of that procrastination. So yes, we treat this. But also you may have subclinical levels of it and you can do some work on your own. There's I think the self-help book, Martin Antony, Anton. He wrote a self-help book on perfectionism, cognitive behavior therapy for perfectionism. So you could even check out his work. Great question.
Dr. Muller, that's exactly what happened to me in college, actually. I think I spent, and my students can laugh at this now, I think I spent a month outlining the first chapter of my thesis in undergrad. And my director finally said, Chen, just give me something.
Give me something.
It's going to be junk because it's your first draft. Just give me something.
That's right.
And that's what it was. And so he gave me a deadline. I turned in 20 pages and he threw it out. But it made the rest of the writing process that much easier, to your point.
So great, like breaking that down and giving something that's good enough. I sometimes have worked with art students, right? So visual arts folks can get caught up in that procrastination, perfectionism thing too. And so in those cases, you know, they want to make that last tweak, and we will encourage them to turn the portfolio in now and see, did the terrible thing happen? They're going to see I'm an imposter, I'm not good enough, or whatever your fear is. You can sort of try to play that out as part of your exposure and see if they really find you out, or if you still get that A, you know, even if you left off that extra sentence. So yeah, it's exposure. It's tough, but it's totally worth doing. Mm-hmm.
We have time for one last question here, actually from another one of my honor students, and he asked, would there be some kind of exposure therapy related to interviewing for a job? And here's his example. He says, I'm a computer science major. One of my biggest fears is doing bad in a technical interview. I understand that the best way to overcome this fear is by taking part in the experience, but I get a little anxious even thinking about or talking about it, since some companies have databases of over 50,000 different coding questions that they could ask. It's hard because I've done my practice interviews and I practice every day, but I still get really anxious every time when I think about it or practice it. What could I do to begin overcoming this fear?
Oh, what a great question. And you have the answer in your question. When you said that when I think about it, I start to get anxious. The problem that we have, so you're doing the right stuff, right? You're doing practice. You've done some like faux interviews or pretend interviews. Maybe you're doing some real ones too for practice. You now have to tolerate your fear, your thoughts and fears. It's not so much about the interview itself. It's what your head is telling you about how you're going to do. So my advice, and this is not, I should make the disclaimer that this is not therapy here, but just some self-help advice would be, the next time that happens to you, you have two ways to go. If you're a good imaginer, if you have a good imagination, sit down, close your eyes, and picture those fears. I'm walking in, they ask me a question, I have no idea what to say. What if I can't cover for myself? All those things, let yourself sit. Set a timer, 5 or 10 minutes. Every time that happens, sit down and do that. Don't fix it. Don't make it okay. Sit with the fear, sit with that thought. If you're not good with your imagination, another way to do this is to take a piece of blank paper and a pen. When those worries and fears start, you start writing them down, almost like a stream of consciousness. I walk in, I'm already anxious, I'm sweating through my shirt, anything that's coming through your mind. The key here is not to fix it and not to walk yourself through a plan. That is just a temporary way to get rid of your anxiety. We want you to feel anxious. And if you can get anxious by doing this over the course of a couple of weeks, I think you might see a real difference. Basically, what you're doing is engaging with your fear instead of trying not to think about it. And this way you can do this on your own. You don't have to actually have an interview set up. So give it a try.
It's fantastic advice. And Dr. Muller, as you're talking, you know, I think what you said today applies in so many other disciplines, and in government and in history and so on. We talk a lot about sometimes just being comfortable with the tension, especially in history, right? You can't, to your point, we can't correct the wrongs of the past,
right.
and we need to learn to sit with that tension if we're going to improve for the future. And certainly something that I think all of us can take from today. And I just want to say thank you again, Dr. Muller, for your expertise and taking the time to join us.
Thank you. I had a wonderful time. Hope everybody has a great day. Thank you so much.
Thank you. And we have put Dr. Muller's information in the chat. Again, her email is kmuller@northampton.edu, and her Twitter is sci-fi.1. And so feel free to connect with her or follow her on Twitter. If you have any additional questions, again, please feel free to reach out. And we're getting a lot of thank yous here in the chat, Dr. Muller. So we are deeply appreciative for the work that you do, and of course, for your continued commitment to our students here at Northampton. That is our time for today. Again, thank you all for joining us. We have one final Spartan Talk this semester coming up next week on April the 29th. We will be sending out that information with Professor David Schwartz from our geography department. If you're curious about what's happening in the Arctic or whatever happened in the Suez Canal with that blockage from a few weeks ago, Professor Schwartz is going to have all the answers for us next week, and we hope you'll join us then. Until then, hope you have a fantastic week. Again, thank you for joining us. Thank you to Dr. Muller. Thank you for the fantastic questions, and we'll see you guys soon. Take care.
Bye now.